Hello, Suchita. Let's start.
Yes, ma'am.
Good evening, one and all, and welcome to the webinar on CME on immunohistochemistry. So today in this session, we'll be touching upon various topics that will enable us to understand precision medicine and exploring the future with immunohistochemistry. So I welcome you all to this session. Suchita, next. Now, a word on a Global Healthcare Academy. Now, this is India's leading medical education tech academy. And here, the paramount mission is to nurture a pool of competent and compassionate human resources, catering to the ever evolving needs of our healthcare sector. Now, this academy firmly believes that technology is the key to unlocking the potential of learning, which plays a vital role in each step of our educational journey. The core purpose here lies in bridging the crucial skill and knowledge gap which exists between whatever traditional education we may have acquired and the dynamic requirements of the healthcare industry in our day-to-day lives. Now, to achieve this, GHA offers a diverse array of 5 academic verticals. So that is GHA conferences, continuing medical education, global healthcare publishing, global dental academy, and allied healthcare. Next, please. I am Dr. Deepa Kurhati, pathologist here at TriStar Sciences HCG, and I'll be your host for today. Let me introduce our course director, Dr. Veena Ramaswamy. She's an experienced pathologist with over 22 years of experience in the field. She specializes in oncopathology and is an expert in gastrointestinal, urogenital, female reproductive system, head and neck, and bone and soft tissue pathology, as well as being skilled in histopathology, immunohistochemistry, and flow cytometry. She also leads digital pathology initiatives across our HCG centers and actively contributes to artificial intelligence and machine learning projects. Several conferences and CME programs have been conducted under her guidance till date. She is also an empaneled NABL assessor and holds a 6 Sigma Green Belt from IIT. Next. Next, Suchita. Welcome, Veena ma'am. What can you tell us about the purpose and scope of this session today? And what are you aiming at towards the CME to be held on 11th of August?
Thank you, Dr. Thank you, Dr. Deepa. On behalf of TriStar Sciences, HCG, and GHA, I welcome you all to this webinar. And it's a pleasure to meet you all online. Histopathology has been, I think there's a lot of echo coming.
Doctor, do you have logged in two systems?
Can you hear me now? Is it better?
Yes, no, it's better, doctor.
Yeah. So histopathology traditionally involves, seeing a tissue under the microscope and then, signing out the reports, and it is known to be subjective. So there are several publications which show the subjectivity to be as high as 20 to 25%. And now we are in the era of precision medicine where, the treatment protocols for every patient is tailor-made. And if you have to have a right diagnosis, just looking under a microscope may not serve the entire purpose. So you need to have a practice of evidence-based pathology. So immunohistochemistry actually provides you that evidence and substantiates your diagnosis. So it's not only for the diagnosis. Now, immunohistochemistry has gone beyond just a diagnostic tool. It has now become a prognostic tool, and it also helps in the companion diagnostics, like that is the targeted therapy choices for the patients. And there is much more that is getting evolved in immunohistochemistry with the application of spatial proteomics, etc. So that is why we thought of having a sort of basic and an advanced what should I say, a CME for people who are the backbones of any histopathology laboratory. That is basically the laboratory technicians and technologists, and as well as postgraduates who are pursuing their career in pathology. So this would be a guide for everybody. Yes, you would have had workshops in immunohistochemistry, and you would at times feel happy that you have done something, in the workshop. But without understanding of basics, just mechanically doing or staining a slide in a workshop would definitely not serve the purpose. So at that moment, you will feel happy that, I got this positive, I got this negative, but ultimately, what are you learning out of it? When your basic itself is not clear to you, just merely doing something mechanically actually will not take you anywhere in the future. That too, the future is all, it's very, very advanced now. So that is why we thought of providing a basic understanding to everybody about what IHC is, and then what is its actual application in IHC in pathology currently, and how is it advancing and supporting the clinicians in the management of the patients. So that is why we thought of having this one day, the CME that is on 11th August.
Thank you, ma'am. So as ma'am said, now it is the era of evidence-based medicine. So with that outlook, what exactly is precision medicine? So in this, we look at patients' genetic sequences, genomics, DNA, and the results of molecular testing, biomarkers, and a complete genetic profile that provides data to the clinicians who can then choose the treatment method that will work best for that patient. So the new paradigm of cancer classification with the WHO Series 5 covers the impact of changes in genes and proteins existing in the cells. So the data collected from the lab tests are then used in customized recommendations for patients. So in recent times, we have seen the evolution of targeted therapy, wherein we specifically target the molecular signature that is displayed by the cancer in that patient, and immunotherapy, where we train the patient's own immune system to fight that cancer. So these are now being the front runners in the treatment of common cancers like lung, breast, colorectal, stomach, liver, melanoma, types of leukemia, lymphoma, as well as other cancers. Next, Suchita. So as I said, here you can see the future of medicine lies in precision, which targets the personalized diagnostics to give right treatment to the right patient at the right time by taking into account differences in their individual disease pattern, general health status, genes, environment, and their lifestyle. Next. Suchita, next. So, immunohistochemistry is now one such tool of precision medicine, which has progressed from very humble beginnings as an experimental technique back in the day to now what is considered as a routine and an essential analytical tool. Multiplex assays for hormonal assays, etc., help us extract more information from less tissue, and improved amplification methods will help us reveal even the ultra low expressing proteins which could have escaped detection via normal measures. There are newer forms of tagging antibodies using nucleotides and quantum dots that may replace the traditional chromogen and fluorochrome protocols. Also, there is next generation IHC that enlists mass spectrometry principles, which not only detects the presence of antigen, but also helps in quantifying the amount that is present, which again has real-time clinical potential. With the advances in digital pathology and whole slide imaging, a significant progress is now made, and the whole slide imaging and digital pathology have now reached a stage of becoming financially viable. So they play a huge important role in immunohistochemistry interpretation as well, and in taking second opinion, etc., from experts in the field. Okay, next. So coming to the topic of introduction to immunohistochemistry, let me welcome Dr. Shaila Bhatt. She's our consultant pathology, a pathologist, holds MD pathology and PD FCC degrees in oncopathology. Ma'am, what can you tell us about the concept of immunohistochemistry? Can you give us a brief introduction?
Hi everyone, I'm Dr. Shaila. So I think Dr. Deepa has explained the most of it. So the concept of immunohistochemistry is nothing but we detect a specific antigen in the given tissue. So it is basically done in paraffin embedded tissue blocks, and we detect a specific antigen located in the cell. By that, we basically exploit the concept of antigen-antibody reaction, where the antibody is labeled, and that antibody reacts with the specific antigen in the cell, and it gives the desired color or the result, which we pick up later by microscopy. So the basic concept in immunohistochemistry is we detect this specific antigen present within the cell.
Ma'am, what can you tell us about the various expression patterns and some diagnostic pitfalls in routine immunohistochemistry?
So the expression pattern includes it can either be a nuclear expression, or it can be a cytoplasmic, or it can be a membrane. So the antigen can be present either in the nucleus, or it can be present in the cytoplasm, or it can be present in the membrane. So whenever an immunohistochemistry is done, the expression will be either in the membrane or in the cytoplasm or in the nucleus. These are the three basic patterns of expression in IHC. And when it comes to diagnostic pitfalls, so there are several which can be pre-analytical, analytical, or post-analytical. So when it comes to pre-analytical, it depends on the fixation of the tissue. It begins from there. So if the tissue is not properly fixed, then the IHC will not work at all. The whole procedure would not work at all. So the antigen which we are looking for, it might be there, but it is not expressed because it was not properly fixed. So that is the main thing. And when it comes to analytical, the presence of when it comes to the analytical, it comes to the whole process, whether there is proper deparaffinization, rehydration, or application of the antibody. So if the technician misses the application of antibody, then your whole, the whole process is gone. So you think that the tissue, process is correct, but it becomes a false negative from your side. On the as a pathologist, you take it as a false negative, but it is a mistake on the technician side. So that is also one of the diagnostic pitfalls. And post-analytically, one antigen can, the desired antigen can be present across many organs. So when you are performing an immunohistochemistry, you cannot rely on a single marker. That is what it tells. One antigen can be expressed in many organs. The examples which I'll tell you in the main conference. So we cannot rely on a single marker. So we should apply multiple markers to come to a specific diagnosis in a given tissue. So these are the various diagnostic pitfalls.
Ma'am, when you say cytoplasmic and membranous, are they the same, or what is the difference?
So membrane is the one which the marker sits in the surface of the cell. On the surface, cytoplasmic is something which is inside the cell, right?
Okay.
So membrane is nothing like plasma membrane of the cell.
Okay.
So where the antigen is expressed, which is taken up by the antibody and which you see as a membranous expression. Cytoplasmic is something which is present in the cytoplasm of the cell.
So now, is immunohistochemistry only limited to neoplastic cases, or is there a role for it in any infectious conditions and other non-neoplastic conditions?
No. Immunohistochemistry is now not only specific for tumor or cancer-related conditions, but also in other conditions, where in infectious diseases, under viral, we have immunohistochemistry for cytomegalovirus, for HSV, for HPV, and for adenovirus, for parvovirus, for EBV, and for herpes HHV8, for polyoma virus, for hepatitis B virus. These are various examples for viral infections. And coming to fungal or parasitic, we have pneumocystis pneumonia and antibody for detection, IHC for pneumocystis pneumonia, for toxoplasmosis. And when it comes to bacterial, we have for H. pylori and we have for Trypanosoma pallidum. So nowadays, IHC is not just limited to cancer-related diagnosis. It can be also used for all these infectious conditions.
Thank you, ma'am, for explaining so well. I'm sure in the main session, you will back this up with all the images to make it more interesting.
Yeah, sure. Thank you. Thank you so much.
Suchita, next. So now, to talk on preparation of tissue and sections for immunohistochemistry, we have a tag team of Dr. Anvita, who's our fellow in tumor pathology, and Ms. Meenakshi, who's a technician in our Department of Immunohistochemistry. Welcome, Anvita. So what can you tell us regarding the importance of tissue preparation step in the IHC workflow and how you arrive at your diagnosis?
Good evening, everyone. Tissue preparation is one of critical is critical in immunohistochemistry, and Dr. Shaila ma'am has already been explained about what is the importance of fixation, pre-analytical, how it causes pre-analytical, analytical, and post-analytical errors. So it involves several meticulous steps which helps us in preserving the morphology and antigenicity. Any deviation in any of the steps may lead to false positive and false negative results. So the first important steps in the tissue preparation for immunohistochemistry is tissue fixation. So the tissue has to be fixed immediately or within 4 hours of the after the surgery. So, and it has to be fixed with the 10% of buffered formalin for a period of around 4 to 68 hours. If there's any under fixation or poor fixation, there's high chances of us getting a false negative results. So it becomes one of the important steps for immunohistochemistry. And there are other several steps like tissue embedding, sectioning. The thickness of the tissue becomes important for the antibody penetration. So any if the thickness is too much, so it will cause, it is difficult for the antibody to penetrate, and it also affects the results. So any deviation in these steps like deparaffinization, rehydration, blocking of non-specific antibodies, antigen retrievals, or primary antigen and antibody incubations, any deviation in these steps will lead to false positive and false negative results. So, and it also affects your diagnostic accuracy and the patient results. So for every step needs to be carefully performed for us to get a reliable immunohistochemistry results.
So here you mean the small biopsies are directly fixed in formalin, whereas the large specimen like modified radical mastectomy, etc., sections to be cut
and it is important to send the small specimens in appropriate fixatives. If the fixative is if they use only saline, and because we get a lot of samples from outside, so it is important to immediately fix the tissue in the formalin, even small or a large. We have to make sure that the slices are thin. We give a 3 mm, like we give a nice cut and fix the tissue for a period of 4 to 68 hours, so that the tissue is fixed and it does not lose its antigenicity. If they don't use an appropriate fixative, then high chances that we lose the tissue and we lose the antigen, which leads us to a false negative results, and it will affect the diagnosis.
Yeah, because you cannot interpret in autolyzed and necrotic tissue, right?
Yeah.
So now can you tell us something about immunocytochemistry and immunohistochemistry? Are they essentially the same? On what tissue do you do them?
Yeah. Both immunohistochemistry and immunocytochemistries are the techniques which are used to detect the antigens. The main difference in both the things is it is that type of specimen on which we are using it. Immunohistochemistry are usually performed on biopsies which are formalin fixed and paraffin embedded, whereas immunocytochemistry is performed on individual cell or cellular clusters, which are usually, we usually do it on cytology specimens like pap smears and body fluids, which are usually fixed in alcohol-based fixatives like ethanol. So the main difference is that the immunohistochemistry is on the tissue which are paraffin embedded and formalin fixed, and ICC is on the cytology smear. So on immunohistochemistry, the antigen detection is at the tissue level, whereas in the ICC it is at the cellular level. So it helps us to detect the antigen at individual cell level, whereas in IHC it helps us to detect the type of antigen in the tissue, and it also gives us a kind of information about the microenvironment, since you have a whole tissue architecture. Whereas in ICC, you have individual cells, so we're targeting the antigen on the individual cells. So it helps us most of the time in giving us a bit accurate decision, accurate diagnosis on a cytology smears, where it is difficult for us to when it is difficult for us to arrive at a diagnosis on cytology smears. So basically, both of them are uses the same technique, but the type of tissue on which we are applying it is different.
Okay, but the essential principle is the same.
Yes, yeah.
Thank you, Anvita. So we now have Meenakshi. Hi, Meenakshi, welcome. So what can you tell us about the routine section cutting done for the immunohistochemistry preparation?
Bhavesh, can you take that question? Okay. Kandaswamy, can you answer that? So just to address the fourth question, control tissue and the routine markers, what is displayed on the screen. Let me tell you, it's always preferable to have a control, whenever you are running your IHC markers, because that gives you the confidence that your test performance is correct. So your control tissue has to show the expected result. And the control can be an external control where you use a tissue that is already known to express that particular marker. It can also be your internal control. For example, you have a breast tissue which has which has a tumor as well as adjacent normal tissue. So that can also be used as an internal control. It's always preferable to have both, but if you are not able to get a section which has normal tissue, then you can as well use the tumor tissue itself, but don't ever forget to run a external control whenever you have this problem. So it's and also it's always preferable to have a known positive control. And there is a recommendation from CAP which says that you also need to run a negative control whenever you are running your IHCs. But you will be unnecessarily wasting so much of material if you try to run both. But preferable is both negative and positive control, but at least one positive control is what is actually recommended. And it's always better to use those controls which are from the patients and which are processed in your laboratory. That is ideal, because that would have undergone the same process as your lab processing. So it would be an ideal control to assess the expression of the antibody. And now coming to the thickness of the sections, I think the thickness would be little more than the routine histopathology. So basically in routine histopath, you cut it at 3 microns. For IHC, it would be around 4 microns is what is ideal. And yeah, and also your microtome has to be cleaned every time, because these are all basic steps that we would tell you in the CME. Over to you, Dr.
Ma'am, and in issue of control, so in each slide, do you only take like the positive control, or is it a conglomerate that you have a positive, negative, and weak control?
There are certain prognostic markers where it would be ideal to run a negative, a weak positive, and a strong positive. But otherwise, just try to run one positive. It's also said that you can run the control on every slide if you have access to the control tissue, or else better to run at least per batch of each marker. So I think we will address this more when we have the CME.
Suchita, next. Okay, next.
No, you ask.
He's not in that. They haven't allowed. Suchita, next slide. So now we have the topic of preparation of tissue microarray and validation of the IHC markers. To enlighten us regarding, we have Mr. Bhavesh, who is our technical in charge for the section of Immunohistochemistry, Tristar Sciences, HCG. Hi, Bhavesh. So what can you tell us about tissue microarray and how does it vary from your conventional IHC slide?
Yeah, ma'am. Tissue microarray means it is a method. It is used to analyze the expression of proteins simultaneously in a multiple individual tissue in sample on a same slide. It is a comparison between multiple cases within a single slide.
So what is the role of this tissue microarray, especially in a large research facility like HCG?
This is a role, very useful role. It is a cost-effective method in our. It is helpful to cost-effective method and faster than the normal ISCs. This technique used to like a IST and fish in situ arbitration and special stains and multiple cores performed on a single slide simultaneously. Are you reading, ma'am?
Yeah, Bhavesh. So now how many markers are validated till now at HCG?
Yeah, we are validated around 150 markers right now.
Okay. So that makes you one of the leading immunohistochemistry centers, right?
Yes, ma'am. And still some more we are going to validating
Okay.
other new antibodies.
Okay. Okay. Okay.
So the team is done for about 150 markers. So
Yes, ma'am.
wherever we do not have we're not able to do a TMA where we want to see the expression of the markers on the entire tissue. In that case, we resort to individual slide. And TMA is also very helpful for validation, right, Bhavesh? Validation
Yes.
of markers.
Suchita, next. So to talk about quality control in immunohistochemistry and selection of appropriate controls, we have our consultant pathologist, Dr. Soumya Biru, who's completed her MD pathology, PDCC hepatopathology, and PDFCC oncopathology. Welcome, ma'am.
Hi, good evening. Good evening.
Ma'am, what can you tell us regarding the importance of quality control in an immunohistochemistry setup?
These days we have been increasingly using IHC for diagnosis as well as prognostic purposes. Hence, the results we obtain through IHC has a direct impact on patient care pathway. Hence, every process of the IHC has to be monitored by maintaining the quality, which is both internally and externally. So internal quality control methods should be carried out like every day with every batch and with every test and every antibody run, and it can also be monitored externally by participating in external quality assurance program, so that we know that we are our processes are at par with the quality standard maintained in other labs.
Ma'am, how do you go about choosing the best control tissue for the IHC assays that you run?
Okay, so first thing is we should take a known positive control. For example, if we are taking for ER, we need to take a breast tumor tissue which has already been reported as ER positive, and ideally it should have a varied intensity of staining. For example, it should have a weak staining, moderate staining, as well as a strong staining within the same tissue, and these blobs should be obtained from the surgical pathology archive of our own labs. We should not depend on external labs or other hospitals for the control tissue, because we need to know what is the pre-analytical factors in that particular tissue block. Has it been fixed appropriately? Has it been processed properly? So all these things we'll know only when we when the pre-analytical factors are maintained properly. And we need to know there should be evidence in the literature or textbooks that this particular marker comes positive in this particular tissue. And also we can also use the leaflets which are provided by the antibody production companies. They usually mention what are the control tissues which we can take, and what are the normal tissues which express that antigen, and what are the tumor tissues, what type of tumors will express those antigens.
Ma'am, and how do you go about identifying the failed control reactions? Like before interpreting the markers, I think we look at the control, right?
Yes. So before even you go and see the test tissue under the microscope, you need to see the control tissue, whether it has worked or not. Okay. For this, you need to know what is the site of expression of different markers. For example, PAC site is nuclear, ER is nuclear, HER2 is membranous. So you need to have the proper knowledge about where these IHC markers are expressed. And then you need to check whether the control tissue you have taken is proper or not. For example, if you're using CDX2, and if you're using appendix for CDX2, by mistake, if the tissue used as a control is a lymph node, you will not see the expression, right, in that tissue. So you need to first make sure that a proper control tissue is used. Then and you also need to know where it is in what way it is being expressed. If you use a lymph node for BCL2, you need to have that knowledge that BCL2 will be negative in the germinal center of the lymph node, and it will be expressed in all the other cells. So this way you should be able to know even the spatial expression of that particular marker in that particular control tissue.
So it begins with first selecting the appropriate control.
Yes.
And also the fixation of the tissue matters.
Yes.
Then can you also tell us about background staining, ma'am?
Yeah, so background staining occurs during the process itself, depending upon the antibody incubation. So sometimes you can see these stains as smudgy staining over the cytoplasm or the nucleus, or even the tissue adjacent to the target. For example, you can have the stroma being intervening stroma being very brown, or you should be able to identify edge artifact because of pooling of stain. You can have non-specific staining. So it is very important to even identify when it is a non-specific background staining.
Thank you, ma'am. Suchita, next. So regarding setting up of this immunohistochemistry lab, manual versus automated, we have our technical supervisor, Department of Histopathology, TriStar Sciences, HCG, Mr. Kandaswamy, who will speak about this. Welcome, sir. Hello?
Ma'am, am I audible?
Yes, sir, you're audible. So what can you tell us regarding the steps that you have seen in evolution of an IHC setup over the years?
Okay. First, initially, let me tell you, it gives me an immense pleasure in joining this webinar, and it's a great idea of doing it. And I completely agree with Dr. Veena madam, what madam had told, that the basic of this IHC is very important. Okay, that is what matters, because when a lot of IHC CMEs are done, they look for results without understanding the basic. Okay, so when coming to the evolution of this IHC technique, it has evolved a lot, man, because starting in the 1940s, where Dr. Albert Kunz demonstrated the first fluorescent dye-based immunohistochemistry. And from then, it was a thought that the antigens are not preserved, or it is lost somewhere while doing paraffin fixed, formalin fixed paraffin processed tissue. And later it was concluded that the antigens are preserved, but it is masked by this process of formalin fixation and paraffin wax processing. And then it came the introduction of heat-induced epitome antigen retrieval. And that was the evolution which started as the first step for the modern immunohistochemistry. It was in 1970s. And later on, the techniques got evolved by using a water bath to heat the tissues, unmasking the antigen so that there will be a clear-cut antigen interval reactions happening and to get a good result. The technology changed as the workload of this IHC has been going on because of this sensitiveness and the clear-cut diagnosis getting by IHCs. So what happened was, in case of water bath or in case of using a pressure cooker and a microwave, we need to look into the number of slides we are processing, and there were a lot of manual errors happening on those days while doing all these techniques. It might be due to various reasons. Firstly, there'll be no proper fixation of the tissues. Later, the preparation of buffers and the understanding of the basic concept of IHCs. Everything we're giving background staining, non-specific staining, repeats, and all. And in the other hand, there was a lot of slides going on, in the sense workload going on, and then the manual IHCs was a little bit difficult task for the technicians as well as the doctors. And then came the evolution into automated IHCs, where considering the capacity, flexibility, reliability, ease of use, and that must be easy, user friendly, and the cost per slide also. The more recently introduced auto stainers, for example, this Daco Omnis and Ventura Benchmark Ultra, where initially it was you need to load the slides and only batch wise you'll be able to run the cases. Whereas now in the Ultra, individual slides can be, as and then the IHC marker is over, you can again load another batch of IHC markers, and it is very precise. At the same time, the staining quality, it is very, very high in case of when compared to the manual. This is the evolution from the manual to the automated. And now in this, again, in the future, there is mass spectrometry coming up, and there's tissue microarray on the it is already proving the IHC world. And it's going to be, again, a tissue microenvironment, ion beam imaging. So there's a lot of evolution happening in the IHC world, madam.
So what is the routine IHC load that you guys get, TriStar Sciences HCG?
Okay, that is we guys. Yeah. So we guys usually get approximately an average of 150 slides per day as the individual markers. And if you consider what is the EPHK, it's approximately 15 to 20, and we get 15 to 20 PDL ones, and at least 5 to 6 MSA panels, along with the other additional markers. So it is approximately
panels.
Yeah, diagnostic panel. So an average of 150 slides per day. And the other thing is that we usually get 3 to 4 repeats in these many slides. So this is the workload we manage every day.
Okay, sir. Thank you. Suchita, next.
Thank you.
Next. So now we have Veena ma'am discussing regarding in situ hybridization and dual in situ hybridization. So ma'am, can you tell us if in situ hybridization is different from immunohistochemistry and how the clinical applications and scope for the same?
Okay, so let me address all the questions together. That makes more sense. The moment you say in situ hybridization, ISH, we usually think of fish, right? Like the fluorescent in situ hybridization is what we usually think of, because that's there for years together. And we all are at least familiar with the name of fish. But what happens in situ hybridization is more or less it's similar to what IHC is. Basically, in IHC, we look at the expression of the protein by a particular cell. And these cells are identified by the proteins that they express. As Dr. Shaila enumerated, there are certain markers that each tissue expresses, and these markers are nothing but the proteins or the antigens that we look on the surface of the, or in different locations in the cell, based on which we just label a cell as what this is. But something similar to that in situ hybridization, what in situ hybridization basically does is that we are trying to look at the particular nucleic acids, right? Or the segments of nucleic acids in the cells, through which we try to identify those cells. So it may be a nucleic acid, or it may even be a certain protein that is expressed by the cell. So based on that, we try to identify the cell of origin. And the second thing is in the technology. So in situ hybridization has a little different protocol compared to the IHC. It's a little longer process compared to the IHC. And the chromogens that we use for identification of the marker is different. In IHC, we use DAB, and in situ hybridization, it's different. It can have a silver marker, or it can also have a different chromosome red marker. So it is basically targeting the nucleic acid sequences, right? So when we talk about in situ hybridization, and as I said, the thing that strikes to us is basically the fish. The problem with the fish is that you need to have a big setup. You need to have a lot of investment for setting up a fish laboratory. Like you need to have an adequate space. You need to have a fluorescent microscope, which is the most important one, and you also need to have people who are experienced in reporting the fish. The other thing is that you need to interpret the fish slide very soon, because if you try to, maybe in an hour or two, you have to interpret the slide. If you try to keep it for longer and think that I will report it tomorrow, you will not be able to do it because the staining fades away. So this is one of the important drawbacks of fish. And if you want to go back to that slide and review it again, you will not have that slide, right? So you can only take images and keep it. So that is another limitation of fish. And again, when you're doing fish and you're trying to look at the expression of these nucleic acid sequences under a fluorescent microscope, you are trying to look at in particular areas. So as Dr. Soumya enumerated, there will be areas where you will have a low staining, you will have a moderate intensity staining, you will have a strong intensity staining. So you will not be able to identify and look at the expression of these markers or in the entire tissue if you're doing fish. So in that way, when we do a dish is nothing but a dual in situ hybridization, where we actually use it's basically applied. It's a new technology that is now gaining much acceptance, and it is currently being used for the interpretation of HER2 in breast, GI malignancies, etc. So basically, what we do here is that we use two different markers that actually. So we use two different markers that will identify the nucleic acids or the sequences of interest, and we try to look and we see the expression of that marker on the routine microscope that a pathologist uses for interpreting the histopathology report. And so you will be able to simultaneously compare your histopathology slide with the dish slide. So you will be able to identify different morphological changes and look at the expression of these areas on the dish. And also the dish slides can be preserved for a longer period of time. So unlike the fish slides. So dish is becoming a more popular technology, which can be done on the IHC platform itself. So you don't have to invest anything. You don't have to buy a fluorescent microscope. You don't need people who are experienced in reporting fish. So that all that is taken care when you have a dish. And if you are looking at in situ hybridization per se, you can also use it for identification of monoclonality, like you have plasmacytomas, where you want to establish whether the tumor is expressing kappa or lambda. So you can easily use the in situ hybridization technology and identify the expression of whether it's kappa or lambda. And ISH is also being used in the identification of viral markers, particularly for P16, the HPV virus. So it can be easily applied for identification of the HPV virus. So these are some of the areas where ISH can be applied on the basic histopathology setup itself. And it will also be, I think it's also going to evolve, and much more markers are going to come into the market, and it's going to be much more affordable. Right, it's a very useful technology. I don't want to give away all the answers, though I have already explained quite a few, but I think I would like to preserve, what should I say, the dessert for the, I think, the seminar. Yeah.
So, ma'am, is dish technology now FDA approved, and is it becoming a routine everyday procedure?
Yeah, because of the limitations of dish is being accepted widely now, and emphasized earlier, fixation, tissue has to be proper. So then only your results will be accurate, similar to IHC, because it's an IHC based thing. So your tissue fixation, handling, everything has to be proper. Yes, FDA is, I think it is approved, I think. I'm not too sure. Yeah. They had applied, but I'm not too sure. But it is definitely CE certified. Yeah.
Thank you, ma'am, for that insight into in situ hybridization. Suchita, next. So now coming to troubleshooting in immunohistochemistry, Mr. Bhavesh will illuminate us regarding the common issues that people face in the day-to-day handling of cases.
Yes, ma'am. Are you hearing, ma'am?
Yes, Bhavesh, we can hear you.
Yeah, commonly we are facing day by day issues in ISC. First, we need to identify the problem with immunohistochemistry. See, the common issues are weak stain or no staining, either high background staining and non-specific staining. So these are the most common issues in the staining. If come to weak stain or no staining means, is not enough. If the not enough primary antibody is come weak stain or no staining, or primary secondary antibodies are incompletable, or if the tissues are dried out, deparaffination is not sufficient, or tissues are overfixed, or incubation time is too short. If it is the problem, if the weak stain or no stain, it will come. If come to high background stain, so whenever you get the high background stain, deparaffinization is not sufficient. Endogenous peroxidase activity, endogenous biotin, either non-specific binding, blocking insufficient. These are the problems that get the high background stain. So come to non-specific staining. When we will get the non-specific stain, antibody concentration is too high. The primary rise again the same species in the tissue stain. If the problem, these are the problems you're getting in ISS.
So once you've addressed the issue like high background staining, etc., now what corrective measures do you take?
See, first we need to ensure the target tissue is present in the block.
Okay.
Then we have to run the same antibody on the another tissue on the same type. If the background tissue, come again, ma'am.
I was asking you how you address the common issues that you face from day to day, Bhavesh.
These are only, ma'am. Common issues are weak stain or no staining, either high background stain or non-specific staining.
I think we keep that for the CME. Let's not give away the answers. Let people attend the CME. We'll show them what are all the problems that they can face with IHC and how to address that.
Okay, ma'am. So moving on, Suchita next. Okay, so we'll also have a session of case-based discussion and slide-based evaluation by Dr. Nikhil, fellow in tumor pathology. Hi, Nikhil. Are you there?
Hello, Dr. Deepa. I'm here. Good evening, everyone.
Hi, Nikhil. So can you give us a glimpse into what sort of cases you'll be discussing in the session?
Yeah, I will be discussing various cases and approach to each case on based of both histopathology, like morphology on HND slides, and immunohistochemistry. Basically, we use immunohistochemistry markers for firstly for categorization of undifferentiated malignant tumors, like whether it is a carcinoma, lymphoma, or sarcoma, on and also for subcategorization of the tumor which we have classified on HND. Like if it is a lymphoma, we would like to know whether it's a B lymphoma or T lymphoma, and also for determination of origin of metastatic tumors, like if there is a lymphadenopathy and we don't know from where from where the tumor is arising, so we have specific IHC markers from which these tumor cells originate. So whether it is arising from lung or any GIT primary or any prostatic primary, and also for detection of molecules that have prognostic or therapeutic significance, like we have ER, PR, and HER2 for breast carcinomas and ALK1 for lung adenocarcinomas. So I will be highlighting, taking up each cases and their. It will be an interesting session with all the radiology and how the patient has presented.
I'm sure you'll run through the gamut of clinical presentation, the radiological doubts, and how with histopathology and immunohistochemistry, you've reached a conclusion in a case which looked confusing. Good. Looking forward to that. So also, what can you tell us about the selection of individual markers versus a broad panel application, like, what we call the shotgun immunohistochemistry methodology?
Yeah.
Is one better than the other, or are they both better in their respective circumstances?
Yeah, like it depends on the firstly it depends on what I see in the microscope on here on HND slides. Like not all that looks round and small is lymphoma, and not all that looks spindle and elongated is sarcoma. So for that, I will be I'll decide whether it is whether a single marker is needed or a panel wise. This thing is also necessary in both theranostic and diagnostic purposes. Whether if it is a myeloma, I'll directly use panels.
Okay.
And gliomas, and we have set of markers under each panel at HCG for sarcoma, for lymphomas and myelomas.
Okay.
And also, if I'm not sure if whether it is going to be any of this, I will go through single markers and go in a stepwise this thing.
Okay, so for a primary of unknown origin, you would prefer individual marker.
Yeah, individual markers. Yeah.
So basically, morphology forms the basis of everything.
Yeah, morphology forms the basis of this, but then immunohistochemistry is both complementary and necessary for final diagnosis.
Thank you, Nikhil. Suchita, next. So now, looking at the smooth workflow of an immunohistochemistry lab, we have Dr. Tejaswini, our senior consultant pathologist, DCP DNB pathology, with about 15 years of experience in the field. Welcome, ma'am.
Good evening, all. Hi, Deepa. You are able to hear me?
Yes, ma'am, you're audible. So, what can you tell us about the significance of this smooth workflow in an immunohistochemistry setup? And does it differ from the routine histopathology section?
Definitely differs from a routine HND section lab, whether be it a manual or automated. So I think my talk would be very less because it is a summation of all the topics that have been covered in the session today. But still, I would like to summarize. We all know that IHC has become a valuable diagnostic tool for the accurate diagnosis and in the molecular classification of cancers in the era of personalized medicine. And it also has a potential to transform surgical pathology from a subjective art to an objective science. So for a smooth functioning of the IHC lab, we have certain technical considerations. So to begin with, tissue preparation, which is the most important prerequisite step for the immunohistochemistry. Then validation of antibodies. So it includes a determination of the specificity and optimal working dilution of every reagent, be it a primary antibody, be it a secondary antibody, etc. Then lot-to-lot validation. So you need to have lot-to-lot verification. Though it is supplied from the same company, you need to have lot-to-lot verification because of the variations in the origin, composition, concentration, and specificity that can occur among different lots. Then we also talked about manual versus automated. So automated staining enhances the consistency and reproducibility of the results. And the next is using positive and negative controls as per the CAP guidelines. Then results and reporting is an area of surgical pathologists. So an experienced pathologist should know to avoid these false positive and the false negative results. And lastly, EQA program and proficiency testing, which is very, very important. So good quality practices. And next, continuing medical education is also important for the technologists. So your knowledge is also improved. So overall, to say good quality practices are very important to get a good quality results, and which in turn is very important for the patient care and outcomes. And most important thing is IHC is not just putting some markers. We need to understand that it is based on clinical radiological histomorphology, and it should be confirmed by IHC testing. So IHC should be used as a cost-effective tool in patient care. So we all discussed that it is IHC is used in MUO, lymphomas, receptor studies, predictive markers, and targeted therapy in this era of personalized medicine. So above all, you need to have a good tentative diagnosis for a successful IHC, and you have to have diagnostic algorithms for the workup of the case. So overall, to conclude, I would say that good quality checks are very important to ensure the accuracy and the reliability of the staining. So you need to have reproducibility and consistency in the results. So this all will make smooth workflow of the IHC lab. So which is very important to get a good quality results and for the patient care. Thank you,
ma'am.
Yeah, thank you, Deepa.
Suchita, next. So, as Tejaswini ma'am mentioned, we are hence hosting the continued medical education on immunohistochemistry with the Global Healthcare Academy on 11th of August 2024, which will be held at the Academy, Jayanagar, Bengaluru. So we hope to provide basic and advanced information on IHC technology, which also will include the steps of troubleshooting, successful application in a histopathology lab via the mode of lectures and case-based discussion. This will enable the participants to learn all about the technology right from the basic grassroots level to the level that they can set it up and run it successfully. So with this, I request my program director to conclude the session. Suchita, next.
Yeah. Thank you, Dr. Deepa, and thank you all the panelists who have been part of this program, this webinar, and given wonderful inputs. And I'm sure that the participants would look forward to getting much more in-depth understanding of all these topics, in the final CME that is on the 11th of August. On the 11th of August, it's a Sunday, and I think it shouldn't be a problem for anybody. So the reason why, as I told in the earlier in the opening itself, it's not purely, I would not call it a pure theory class. I mean, it would include, demonstrations, probably through slides slides and some images of how we handle all these tissues. So we are an oncology lab, and as Kandaswamy said, almost like 150, 180 slides we have every day, and we have all the markers like diagnostic, the prognostic, and targeted therapy markers, etc., and including the ISH markers. So it would be a good experience for people to get a hang on what is happening in IHC, and also it would be interesting to understand from the experts, because all of us are with working with IHC day in and out, and we handle so many cases, not only cancer but also other cases as well. So it would be very interesting to learn from all the experts, and you will understand how from the basic handling of a tissue to the final interpretation of the result in the final CME on the 11th August. So I would request all of you to attend the CME on 11th August, and it would be much more informative. You just had a glimpse today, and I'm sure that you all would like to know more about it, because as I said, IHC is not the future. I mean, there were days when people used to say IHC is the future, and we don't have access to that, but IHC is no longer the future. It's already the present, and with so many evolutions happening, I don't think it is going to be a future anymore. It's already the present, and it will continue to be the present with application of so many interesting diversities in IHC. I mean, and it's also, as Dr. Deepa spoke about precision oncology, there are so many biomarkers that get detected or discovered on the IHC platform itself. So it's always easy to it's always required to understand the basics and also learn what is happening in the field. And this could itself be one of a career opportunity for a lab technician. You will have opportunities in all these pharma companies, and people who are working on biomarker research, and also people who are working on machine learning and artificial intelligence. It would definitely be a career path for all the lab technicians. And as far as postgraduates are concerned, it would be interesting to understand the basics. I mean, not leave everything to the technicians, but understand the basics, understand the knowledge, and then you would also be able to help the technicians in troubleshooting and also in the interpretation of the diseases. So I hope to see you all on the 11th August, and I hope you will have a wonderful session. Thank you so much. So we thank you on behalf of TriStar Sciences, HCG and GHA for attending this webinar, and please do register, and we look forward to see you all. Oh, sorry, I forgot. There's something interesting. Quiz. Yeah, Dr. Arya, you want to say about the quiz?
We're planning something, ma'am. We will be planning on based on the 3 levels of quiz. Like we'll start from we are planning to conduct for the 3 levels, like easy questions, like medium level, then it will go to the difficult level, and of course we are planning to come up with so many questions, and we will rewards also will be provided for it. Hope it will be a good thing.
So I do look forward to the quiz. Yeah, so it'll be interesting to understand, to know how much you know about it, and how this this CME is going to help you in your day-to-day practice. So thank you everybody, and thank you GHA for helping us come out with this webinar. And thank you everybody. I look forward to seeing you all on 11th August. Please do register. Thank you.
Thank you, ma'am.